Is it true, Chrissy, that CRNAs are never going to do any big cases, especially not in New York?
No, Anna. No, it is not.
This is something I think that is poorly understood even by people who are in CRNA school, and I've even met CRNAs who don't really fully understand practice and state licensure and all of this stuff. So I think this episode is going to be really helpful for people to kind of tease out some of the nuances that exist between state to state facility. All of this stuff is stuff that is super applicable if anesthesia is something that you're interested in.
Yeah, so one of the most common misunderstandings is that in certain states, you're not going to be able to do certain cases, right? I have CRNAs asking me that all the time. You're in New York. How is it possible that you're doing X, Y, and Z? Or, oh, what's the practice really going to be like in Philadelphia, right? For those of you who aren't familiar with nursing practice laws, New York and Pennsylvania, the two states I've practiced in, are the only two states in the country where we're not considered advanced practice registered nurses. And we'll talk about what that means in a little bit. But the bottom line is that the types of cases you do as a nurse anesthetist are going to depend on the facility that you work in. It doesn't matter what state you're in. If you're in a large academic medical center, the priority is always going to be the residents learning, right? Just like you have to have a certain number of cases to graduate and become a CRNA, so do the residents. The residents are also free labor, so they're always going to be prioritized. That being said, even in these facilities, there are often really great learning opportunities and the opportunities to do big cases for CRNAs because there's volume that requires it. Mm-hmm. So I remember when I was a nurse back at the hospital of the University of Pennsylvania, my first job was in the CVICU, and people used to always tell me, there'll never be a CRNA at Hub. And then I graduated CRNA school, and they had a core group of about 5 CRNAs at Hub, and everybody told me, oh, they only do GI. Well, that wasn't true at all. Those CRNAs were actually in the main OR doing big cases all the time because that place is a madhouse and it is all hands on deck. There are so many cases. The volume is nonstop around the clock and they needed all the help they could get. So we ended up actually expanding the CRNA group and even starting a CRNA cardiac team, something I was told I would never do, especially in a facility like Hub. And I loved working there. It was probably the best job I'll ever have in my life. So it's really interesting that like a lot of people will opine or presume what could be possible, and they have no idea that CRNA practice really is just going to depend on facility needs. So whether you're in a fertility clinic, dentist office, podiatry office, GI center doing independent practice, working just like contracting yourself out to, private practice providers, whether you're in a rural hospital, 90% of rural hospitals have independent practicing CRNAs. A mid-sized community hospital where we'll get into like different practice models that exist in places like that, or in a large academic facility, it's always going to be based on the needs of the facility. That's really what's going to, at its core, determine what your practice looks like.
I really like that last sentence, that what your day-to-day looks like will be dependent on the needs of the facility. I think people often conflate the two, that the needs of the facility is what you are allowed to do, or that is your quote-unquote scope of practice to do. And I think that's something that's poorly understood. Because at the end of the day, like you said, your day-to-day, your day in and day out is going to look like what the facility needs you to do. Now to kind of get into the next point, what are we trained to do as CRNAs or RRNAs? And how does that kind of go throughout the country and relate to like Pennsylvania and New York?
Well, your scope of practice doesn't change from state to state. That's also something that's a very common myth or misunderstanding. Your scope of practice is determined by the Supreme Court. According to the Supreme Court, when anesthesia is given by a nurse, it's considered a practice of nursing. And when anesthesia is given by a physician, it's considered a practice of medicine. If you don't like it, don't come for me. You guys can take it up at the Supreme Court. That is something that was decided with several court cases many, many decades ago. But that's the way it works in the United States. So your authority to give anesthesia comes from you being a registered nurse who's attended CRNA school and who's passed your board's exam, the NP-CRNA. And that's where your scope of practice comes from. There are no limitations on that based on state technically, in all 50 states, CRNAs do practice anesthesia independently, even in New York, Pennsylvania, and New Jersey, which actually has some very specific, interesting laws regarding our practice as well. But we do practice independently everywhere, depending on facility.
So that ties into the differences between practice authority and billing practices, right? So 22 states, I believe now, have opted out. What you're saying now is that even if you work in a state that has not opted out, for billing purposes...
She means opt out of the Medicare supervision requirement. That's what opt out means.
Yes. So even in these states that have not, quote unquote, opted out, your training and your practice, you can still practice to the fullest extent of your scope in states that have not opted out yet. This is where you have a nuanced line between billing and practice and practice models, and it gets pretty blurry. But I think this is something that is poorly understood.
This is going to have to be its own episode. But the short version of that is that there is no law in the U.S. that requires a CRNA to work under a doctor. In order to be reimbursed by Medicare and Medicaid, specifically, CMS requires a CRNA to be supervised, that's a billing term, by a physician. There's two caveats to that. One, they do not denote the type of physician. So that physician could be a podiatrist, it could be a dentist, it could be a plastic surgeon, a fertility doctor. They do not have to be an anesthesia provider. And again, they have allowed this process called opt-out, where if the governor of a state decides that this is inhibiting patients' access to anesthesia services in their state, the state can opt out of that requirement. So now 22 states no longer have that requirement at all. It's also important to note that if you are contracting yourself out to work with a podiatrist, a GI doc, a plastic surgeon, etc., in a non-opt-out state, you being supervised by them does not increase their liability. So they do not take on the anesthesia risk, even though they've entered this collaborative agreement with you. So all it means is you have to have a contract with them. So it's very interesting in how...
There's a lot of nuance here.
It's a lot of nuance. And at the end of the day, it doesn't actually affect your CRNA practice at all.
I think a lot of people operate under the assumption that CRNAs only do independent anesthesia in opt-out states, and that is not true.
It's not true. There are... I remember... Actually, as a matter of fact, even in my old academic medical center setting, we absorbed a very tiny community hospital in deep West Philadelphia. And for a while, we were covering the airway call solo there. So we would take 24-hour shifts where we were the only person in-house who would intubate the patients. And our collaborating anesthesiologist was on call from home up to an hour away. So you would be independently placing lines and intubating these patients if needed, even though we were in the big behemoth of an academic system. So that was kind of interesting, right? We also see in Philadelphia, lots of fertility clinics and small GI practices hiring independent CRNAs. Even here in New York City, there's plastic surgeons who have a one operating room office, and if they want to hire you, you're good to go. So that's something that people just really need to understand. It's all about the individual facility that you're working at. And even if you go to an opt-out state that is viewed as CRNA friendly, quote unquote, if you go to a large academic medical center in a large urban area, your practice is going to look the same as if you're in another state that is more famous for being, quote unquote, less CRNA friendly.
I think that leads in nicely to kind of the next talking point, which is talking about different practice models, right? And this is stuff, I know it's a little dense to listen to, but if you want to go to CRNA school, you need to know this stuff. You're going to be asked about scope of practice. You're going to be asked about opt-out, billing. These are things that relate to your future career. And this is stuff that is really helpful and relative to you if you are interested in anesthesia. So a few things you mentioned practice models. Do you want to talk about like a few of the different practice models that you're the most familiar with?
I think it's important for people who are interested in becoming CRNAs to understand that, yes, you can be independent or you can work collaboratively with a physician. Most people are going to work in multiple practice models throughout their career. So if you join the military, for example, in most settings, CRNAs in the military are independent and they're used to the full scope of their capability. If you get deployed to an active war zone, you're going to be doing nerve blocks on the fly to people whose legs just got blown off. I mean, the stuff that these CRNAs do in the military is very ahead of its time. You're going to get amazing training and you're going to be a very strong clinician. Conversely, there's also anesthesia care teams in the military if you're at a major base in a very populated area, like one that's based out of the US, for example. Then there's rural facilities in the US. I think we already mentioned 90% of rural facilities are staffed by independently practicing CRNAs. We also have those in-between hospitals, right? Most hospitals in the US are that in-between. They're mid-sized community hospitals. So these suburban area hospitals, they're often operating under either an anesthesia care team. They could use either medical direction or medical supervision. So it could be one physician with up to 4 operating rooms with a CRNA in each room. That would be called medical direction. Or medical supervision, they could have up to 8 rooms with a CRNA in each room. If they have a learner, however, if there's an SRNA in a room or a physician resident in a room, they can only have 2 rooms at a time. So these are like important things to understand. On the flip side, we also have collaborative anesthesia teams. So these are really popular in Arizona right now and are definitely gaining popularity as the word's kind of catching on. And the way that they do things is it's a staffing model where you optimize the best person for the best room. So you have 1 or 2 people out who are free to run the board, give breaks, be an extra set of hands in case of a challenging anesthetic or an emergency. But if someone has an expertise in regional anesthesia, they're doing the blocks that day. If someone has a background of cardiac, they're going to do the cardiac case that day. We're going to optimize people based on their training, their preferences, and their skill set, not necessarily their title. Everyone is getting to work to the fullest extent of their training.
And the CAT, from my understanding, after going to mid-year conference with AANA, is really the most cost-effective and like safest model because you end up using your entire team, and then instead of having somebody pulled out of the numbers who is only like supervising other people, you get really everybody hands-in, kind of involved and working together. And then you have that blended skill set of people who have a ton of regional experience or people who have a cardiac background. And you're saving the facility money, and then you end up just kind of optimizing the workflow, which is huge. And also one kind of note for people who are listening, look up and differentiate that the medical direction versus supervision is a billing delineation, and this is about reimbursement for the hospital from Medicaid, Medicare. It's, again, about the billing practices and then how they set up their facility. So, Chrissy, as somebody who's been a CRNA for about 5 years, you've worked in a couple of different anesthesia facilities, a couple of different like practice models. What would you say to somebody who is like an ICU nurse who's interested in CRNA, or somebody who is just pre-anesthesia about what kind of cases and what kind of like skills CRNAs perform? Like, do you do procedures yourself? Like, what does that actually look like?
Yeah, I think this is like one of the biggest common misconceptions. So when I was an ICU nurse, my background was CVICU, right? So I always assumed that anesthesia would look kind of like that experience, right? I pictured cardiac surgery and patients being on lots of drips and me titrating them up and down and maybe having a really high dose propofol infusion. I didn't really understand that inhalationals existed, or there's tons of types of anesthetics, or that sometimes doing an endoscopy on a patient without an advanced airway is actually more challenging than some of my cardiac cases. So it's really important to know that we have just such a wide variety of things you're going to encounter in your career. Not only are we doing cases like in vitro fertilization, colonoscopies, endoscopies, general surgery, plastics, but yeah, we're also in the craniotomies. We're also in thoracic rooms. We're also doing cardiac anesthesia. I used to take trauma call where people would come in with bullets all over their abdomens and heads. It was insane. The sky is the limit in your anesthesia career. And again, it's going to depend on where you choose to work. Along with that, the types of skills that you perform are going to be determined by the types of cases you're in, right? So that looks like placing arterial lines. If you're in cardiac, you're placing a lot of central lines. You're floating swans. There's a big misconception about transesophageal echocardiography also. There are CRNAs all over the country who do TEE all the time. Now, if you're in a big academic center where you have cardiac anesthesia fellows, the main point of their fellowship is them to learn the TEE. So you're not going to be really playing with the TEE probe that much unless you have some downtime and somebody wants to show you. But there's nothing prohibiting you from developing that skill. And actually, at my old job, I was getting to learn it a little bit there, and that was like a really fun part of being on cardiac for me.
It's huge.
Similarly, I'm back on the cardiac team again at my new job, so I'm really excited about that as well.
Both places that people said CRNAs would never do hearts, by the way.
I know. Everyone told me, there was a motto at my old job, there will never be a CRNA at Hup. And not only did we expand a CRNA team, we brought in RNAs, and we also started a CRNA cardiac team. So that was pretty cool.
And this is in Philly and New York City.
Yeah, in New York we have, the same thing again. They told me that I'd never get to do cardiac at my new job, and I've been there for 6 months, and I'm going on my 6th year.
Chrissy's like starting the cardiac team there.
Okay, I wouldn't go that far.
Well,
but it's like me and one other person who are going to be in the open heart rooms for now, and I'm excited about it. I'm having a really good time. But placing SVC drains, they're these giant lines that we put in patients. Epidurals in OB, I've gotten really good at epidurals over the last 6 months. That's been really fun. Spinals, I mean, the sky is really the limit. What have you seen out on the West Coast? You've done a little bit of shadowing. I know you haven't hit clinical yet, but you've seen something.
I'm pre-clinical, so this is really, it's just a bit too soon to know, but I am really interested and excited about the opportunities to have rotations kind of throughout the West Coast. I know that I'm going to have at least one rural anesthesia rotation where there's 1 or 2 CRNAs and then you're taking like 24-hour call and you're it for the population within that area. Namely in Idaho and Washington, like rural Washington, rural Idaho. I think that's going to be really interesting. A few of my faculty have completed the pain fellowship, which is really cool because so they have really strong emphasis in regional anesthesia. I think that's something pre-CRNAs don't necessarily know, that you can specialize in anesthesia. You can specialize and you can do a lot of regional, you can do a lot of blocks, which is something that's really interesting.
For the people who don't know what that means, when she talks about regional, specifically, so regional anesthesia includes, like, yes, epidurals and spinals, but also nerve blocks. So that's when you take a needle. Typically, you're using ultrasound guidance to guide the needle, although there's actually, technically, you could use nerve stimulation as well. But you're usually using an ultrasound to guide the needle to being, like, right next to a nerve bundle, not in it. And you inject local anesthesia around the bundle of nerves. And then you can numb an extremity. So that could be good for lower extremity surgery, upper extremity surgery. There's also truncal blocks, so you can numb the chest wall, you can numb portions of the abdomen, and really reduce the amount of opioids a patient needs during surgery, and just like help with their pain management in general. There's also that acute pain fellowship where you could learn more advanced block techniques, like for people with chronic pain or even cancer pain, and they're learning how to do blocks under like fluoroscopic guidance, fluoroscopy. Say that 10 times fast. But it's like a really interesting subset of anesthesia. One thing I want to clarify, yes, you can become an expert and subspecialize in anesthesia, but most people who do that, you're still practicing in general ORs as well. Like usually, even for the physicians, this is true too. Like, even if you become like a cardiac anesthesia person or an OB anesthesia person or a regional anesthesia person, you're also still doing other types of cases as well, because usually facilities need you to be in all the rooms. So you still need to be comfortable going in and doing, the OMFS case where they're doing the jaw surgery, right? Or a maxillary facial surgery. You still have to be comfortable doing the knee replacement. You might, be thrown in OB one day when they're short, but then the rest of the time you're on the block team, right? So yes, you can specialize, but it's quite rare to only do your specialty. Usually you're doing your specialty and everything else.
Which I think ties into how you have experienced really kind of opening doors for CRNAs at all the facilities that you've worked at and really ushered in some really cool opportunities. And how, I guess, what advice would you give to people who are now entering as RNAs and then people who are now entering the field of anesthesia as like a new grad CRNA, as far as like opening opening doors and like opportunities for themselves in terms of like their continued training after anesthesia school.
Yeah, so the number one thing I would say is to stay inquisitive, look at everything as a learning opportunity, be teachable, be likable, and if you don't ask, the answer is always no. So when you enter your first job as a CRNA after school, I encourage you to go somewhere where you're going to get a wide variety of cases as your first job, if you can. Go somewhere that's going to push you. Go somewhere that's supervising. Go somewhere where you're going to have people push you hard and challenge you and tell you no and make you do things in a way that's different. You have not established a practice yet in your time in anesthesia school. Look at it as your CRNA fellowship and get on a team and develop a skill that you're passionate about. Get on an OB team, get on a pediatrics team, get on a cardiac team, take trauma call, get in those rooms and be taught by people who really know. The CRNAs that I worked with at Penn, at both Penn Presbyterian and the Hospital University of Pennsylvania, were amazing. I mean, the amount of knowledge that I gained by being in the trauma rooms and the cardiac rooms with other CRNAs, or people taking over my cases or giving me breaks and giving me insights, and the physicians who, you know, many of them were leading the research on new subjects or leaders in the field. The amount of things that I've learned from my colleagues at that institution, it really made me a strong clinician. And I think that's what equipped me to go into my new job and to, you know, dive in with both feet into a new department and be really welcomed quickly. Gaining a new skill set. I haven't done OB since school. Now I've been on the OB team. It's been a really good learning opportunity. I'm learning a lot really quickly. And I think that like adaptability, flexibility, it makes people want to give you opportunities. They want you to be good and they want you to succeed because they like you and because you're adding value to the department.
That's huge. So similarly to when you choose your first new grad nursing job, I think there's a lot of value to choosing somewhere where you're going to be pushed and you are going to learn a lot. I do see some people coming out of coming out of nursing school and coming out of anesthesia school are two different things. You do graduate anesthesia school ready to practice day one. You don't get or need a long orientation. I think that's something people don't realize.
You will probably get 1 day of orientation, maybe 2.
Like, they just get, here's
the supplies, go.
Here's the supplies, you're completely independent.
Do you know Epic? Great, go.
Yeah. So it's not this whole, like, orientation like you get coming out of nursing school, because you really learn how to be, like, an ICU nurse as a new grad on orientation. You learn how to be a CRNA in CRNA school, and you graduate ready to be a CRNA. At the same time, if you invest the first couple years out of training somewhere where you're going to really get increased volume in a few things you're interested in, like OB anesthesia, trying to get in like the hearts team, this is stuff that's going to only open doors for you down the road. I think there can be, sometimes people are tempted early to hop into the locum stuff, but then it can be, you can go back and then join a different team and then, like you said, like pick back up OB, even though it had been like 5 years since you had done that in school. But I think, you know, if you can view your first year or two out of school as like continued education in a way, like you're continuing to learn and like learn from other people around you, you can really just like have a stronger clinical set, right?
Definitely. I mean, I'm going on my 6th year of being a CRNA now, and my 6th year anniversary will be July.
Oh, wow.
So almost 6 whole years practicing.
That's awesome.
And I've been able to bring that skill set of trauma and cardiac to my new facility's OB team.
That's huge.
So during like massive postpartum hemorrhages, which happen occasionally, which is why OB is so scary, I've been able to place central lines on patients, lead codes, lead resuscitations. That's a skill set that I developed by working in a high volume trauma center. So you can provide value to a department and open doors for yourself that way too. That was also what led to me being asked to join the cardiac team, was me demonstrating that skill in another part of the hospital in OB. So that got back to leadership, and I was welcomed onto the cardiac anesthesia team, which is a place that I was told I'd never go. So it really is important for you to be flexible, be adaptable, and seek out those learning opportunities. I think a lot of people hear what's possible and they just assume it's going to stay that way. It's important to understand why. Well, why is it not possible to be on this team? Oh, because the volume's not there. Well, when the volume picks up and you know that there's been a change, then ask the question, hey, now that there's more volume, is there a need? Can I be beneficial here? If I switch my schedule to give you more nighttime coverage, would that be helpful? Sometimes you have to make a deal. Most of the time, it goes back to your practice is going to depend on the facility needs and the department needs.
Yeah.
Like the politics fall to the bottom when money talks. When they need a body in the room, ultimately, that's when you're going to end up there. So look for those opportunities and create them for yourself.
I think that's a great tip for anybody, kind of regardless of whether you are in nursing school, if you're in anesthesia school. Look for opportunities and create opportunities for yourself. I think that's really wise. Speaking of creating opportunities for yourself, our next episode is about nurse entrepreneurship and what we've learned as business owners for a year now.
Yeah, we're coming up on our year-long anniversary of running Confident Care Academy. We're really excited about that. Life really is all about creating your own opportunities. One thing that I like to preach over and over and over again is that you do not have to become a CRNA to be wealthy or to build wealth. In fact, there's many people who have high salaries who are not wealthy because they don't know what to do with their money. And there's also plenty of people who, as bedside nurses, have the opportunity to build wealth. And nurse entrepreneurship is one of the ways you can do that. So as nurses, you are uniquely equipped with a skill set and a mind to do that. So definitely come back and check out that episode. We really want to empower you guys to really just take your future into your own hands, whether that be your CRNA practice or creating, again, your own life opportunities. So like and subscribe so that you know when that video drops, and we'll see you next time.
Bye.